Huge hypodense mass with a little focus of extravasation in it, in an otherwise young female. So this is a hepatic adenoma, and as I'm sure you know, they have a tendency to hemorrhage, either intralesional as this one is, or sometimes it can be intraperitoneal hemorrhage as well. Little foci of extravasation at the periphery of this, and you can tell that a lot of that hypodensity centrally is actually accumulating intralesional hemorrhage. So this was the typical demographic, typical outcome for this patient. She did well, actually, this being a benign tumor. So that is a hepatic adenoma with the classic complication of hemorrhage. This is one of my favorites. I used this in the Jeopardy game in March, so you might recognize it. This is another one from my private practice days when my friend Cameron called me up and said, "What is this?" So there's a mass in the gallbladder. So you're already thinking strange things, right? It could be a gallbladder carcinoma, of course, but then melanoma and breast cancer metastases are probably the two most common things you'll see there. Note there's a duplication of the IVC, which is inconsequential here. We go lower, there are masses in the omentum, which is pretty unusual. So now you're thinking metastases. But then look at this. In the buttocks musculature, there are hyperdense, hypervascular masses, and that's what sealed it for me. I remember looking at this and saying, "Cameron, this guy's got melanoma." And he said, "Well, doesn't say anything about that in the history." Well, you know, that's pretty typical situation in radiology. So he called me back about an hour later, and I always remember I picked up the phone and he said, "Dr. Strong." So this patient had had melanoma 20 years before. It's one of those tumors, kind of like breast, where the window really never closes, right? You can get them so late. This is another one that demonstrates the importance of that retroperitoneal node, right? You can see I circled it here on the left. This caught my eye, right there. And I always remember presenting that at our tumor board and saying, "That's what caught my eye first," and made me say, "There are Mets." And someone said, "Oh, come on, that." I said, "I look there every time and it's always clean." Right? That can be a really valuable tip. All right, so that is metastatic melanoma. This is a classic. So there's intrahepatic ductal dilation. Mural gallbladder calcification, which you will see is quite extensive. But there's an area where it is rarefied and kind of fuzzy looking with a soft tissue density. And that's the focus of gallbladder carcinoma that develops in these patients. So there is more gallbladder calcification. It's particularly impressive on the coronal. So there's the intrahepatic ductal dilation. Huge distended calcified gallbladder. And look, there's that rarefied calcium with a soft tissue mass extending up into the portal region. And it's actually that's causing the biliary dilation. So there's that biliary dilation. Then we can follow that down. There's the soft tissue mass, right? And there is the remainder of the calcified gallbladder. So we'll look at that on the axial one more time. So intrahepatic ductal dilation, right? There at the confluence is that mass sticking up from the neck of the gallbladder. And there, the distended calcified gallbladder. So let's look at that on the coronal now. Right up at the top there near the gallbladder neck. See that soft tissue density? That's what's causing all that biliary dilation. And that is where the gallbladder carcinoma developed. Right, so a classic association, really nice case of it. Gallbladder carcinoma. Next, this one has intrahepatic ductal dilation as well. This is basically just a classic pancreatic adenocarcinoma. but I wanted everybody to have this in their instant diagnosis file. Right? So here is the enhancing mass in the pancreatic head, and this shows a couple of very important findings that are worthy of note here. Ductal dilation and distal pancreatic parenchymal atrophy. They will often happen together, but those are the two findings you always look for to determine a pancreatic malignancy. Right? These are particularly seen with malignancy, and they're so useful. When I see a pancreatic mass, sometimes the mass itself can be really tough to discern, and it looks almost like a contour abnormality. And the thing that tips you into saying that's a carcinoma is the presence of ductal dilation or distal pancreatic parenchymal atrophy. I have been there a dozen times, and I can tell you it can be an extremely helpful hint. Right? Obviously not necessary here because that mass is distinct, large, and the degree of ductal dilation and atrophy are such that no one could miss it. You can also see another of my favorite findings in pancreatic carcinomas, which is gastroepiploic venous dilation. Right? That is a sure sign that the SMV or splenic vein are out. Right? And you can see that there's no SMV right next to the SMA. And if you follow the portal vein there, it just disappears. Let's go back. So we're going to look at the mass first. Okay, so you've got ductal dilation down to the pancreatic head mass, and there's that distal ductal dilation and pancreatic atrophy. Okay, so now this time let's look at that portal vein. Again, the ductal dilation. The duct disappeared, right, in that intervening segment encased by the mass. And now we follow the portal vein. It just disappeared, and it will reappear as SMV on the other side of the mass. Now, you see that massive dilation, the gastroepiploic vein, right there. See how it's running around on the greater curvature of the stomach and ultimately feeding back into the reconstituted superior mesenteric vein. That gastroepiploic venous enlargement has helped me with this so many times I can't even count. Right? The pancreatic mass is identified, but is it or is it not involving the SMV? Sometimes can be hard to tell, but I go look for that gastroepiploic vein, and it helps me every time. Right? It tells you, you keep looking until you see the SMV occlusion. All right, so that is a classic pancreatic adenocarcinoma. This one is a don't touch lesion, multicystic pancreatic mass, smooth borders, no distal atrophy, no pancreatic duct dilation, and a coarse central calcification. Classic appearance of a serous cystadenoma. That is a benign tumor, so a don't touch. And it'll have a bunch of septations, and it's multicystic in appearance. That central calcification, also very characteristic. This patient just happened to have a small bowel obstruction, you probably noticed, but it was completely unrelated to this pancreatic mass. And again, no distal pancreatic duct dilation or atrophy of the parenchyma. See that tail? It's perfectly normal. So that's a serous cystadenoma. All right, another classic, an islet cell tumor. You can see that rounded, enhancing, dense mass, completely different in appearance from the adjacent pancreatic parenchyma. And there it is. So a neuroendocrine tumor. This one was actually non-secretory, and so it took a lot of doing to convince some of the referring clinicians that it was actually there. And the one thing I'll tell you from experience is be very careful about, because these enhance so brightly, be very careful you don't call a splenic artery or venous aneurysm an islet cell tumor. You can see this is distinct from those vessels, but that's something you always want to check. And this one, this is one of those cases where we just imaged the hell out of the guy. I've got MRs and intraoperative ultrasounds and everything you can imagine. This was hypervascular and enhancing throughout. It really read all the books and followed all the rules. That's an islet cell carcinoma. This is a doozy. This was dropped in the teaching file by Cameron, different Cameron, Cameron with a K. Thank you, Cameron. He dropped this in, and it is just a classic, classic case. So there's the pancreatic head mass. You can see that enhancing soft tissue mass. Look at this ductal dilation and pancreatic atrophy. There is no normal pancreatic parenchyma present. This is all massive, dilated, tortuous pancreatic duct. And then if we go down a little lower, the classic finding is that soft tissue mass in the head of the pancreas is sticking its nose out, herniating out through the sphincter of Oddi. And this is the classic appearance of the intraductal papillary mucinous tumor. What happens with these is they produce so much mucin that they dilate up this duct, and the pressure becomes great enough that it actually forces the mass component out the sphincter, right? So that herniation is a result of all the backup, all the secretion that has dilated up the remainder of the pancreatic ductal system. So you see that kind of herniation out there in this setting, that is definitely IPMT. Very, very nice example. All right, our next one is an adrenocortical carcinoma. So it's very important, I'm sure everybody knows it, but the vascular invasion tumors, we've already alluded to two of them, right? The hepatocellular carcinoma tends to invade vascular structures, and that can be portal or hepatic vein, right? The renal cell carcinoma, of course, has a tendency to invade the renal vein, as we saw in our first case. The other one is the adrenocortical carcinoma. That has a tendency to invade vessels, specifically veins, as well. And that's what you'll see here. So there's a big heterogeneous mass arising from the left adrenal. And there it is extending into the left renal vein. You can see that nose right there, actually extending even into the IVC. So there is the movie version of that. You can see that nice distortion of the adjacent renal superior pole, showing that this is of adrenal origin. And look at that, it's going down the gonadal vein. So here you see it again. Again, the distortion of the superior pole, the extension into the renal vein and IVC, but now watch under the major portion of the mass, it's filling the gonadal vein. Is there a better way to see that? Yes, there is. Here it is on the coronal. It's pretty striking. There's the mass. There is the left renal vein and IVC invasion. But look at that. The upper portion of the gonadal vein, right, the left gonadal vein, which comes off or feeds into the left renal vein, is also invaded. And you can see it doesn't actually reconstitute until pretty far distally there, right at the inferior aspect, near the inferior aspect of the kidney there. So a great example of venous invasion going in multiple directions by an adrenocortical carcinoma. So there's the mass, and there's the renal and the gonadal venous invasion. Again, that distortion of the superior pole of the left kidney, definitively proving that this is a mass of adrenal origin. So venous invasive tumors, very important to know that short list. All right, adrenocortical carcinoma.